Right now, somewhere in this country, an 80-year-old patient is sitting in a pre-operative room being asked to sign a consent form. The surgeon has already explained the procedure. The paperwork is ready. The only thing left is a signature. And in the next few minutes, that patient is going to make a decision that could add years to their life, or take years away from it. I need you to understand something before that moment ever happens to you or to someone you love. Today, I am going to walk you through 5 specific surgeries that carry hidden risks most patients over 60 are never fully told about before they sign. Before we get into that, if you want more honest conversations like this one, the kind that happen in a doctor's office and not in a rushed 5-minute appointment, take a moment and subscribe to this channel. It does not cost you anything. And it means the next hard question you should be asking reaches you before an appointment, not after one. By the way, my name is Dr. Matthew Clark. I am an internal medicine and preventive health doctor, and for the last 15 years, surgeons have called me in constantly to help decide one specific thing, whether an older patient's body can actually survive the operation being planned for them. I am not the one holding the scalpel. I am the one sitting with the patient and the family beforehand, reviewing their heart, their kidneys, their medications, their overall strength, and afterward, helping them recover from whatever that operation cost their body. Before I go further, I want to ask you something. Has a doctor ever told you or someone you love that surgery was simply the next step with very little discussion of what else might be possible? Type yes in the comments if that sounds familiar, because what I am about to share changes how that conversation should go, for you and for anyone in your family who is over 60. Here is the number I want you to hold on to for the rest of this video: 5. 5 specific surgeries that carry hidden, serious risk for people over 60. Not because surgery itself is dangerous. Surgery saves lives every single day, and I want to be completely clear about that from the very beginning. But for an older body specifically, some of these 5 carry risks that rarely get explained in full before the consent form gets signed. I am going to walk through all 5, one at a time, and I promise the one that surprises people most is coming later in this video. Right now, without getting up, I want you to make a fist with one hand and hold it as tight as you possibly can for 10 seconds. Notice how much effort that takes, and notice how quickly your hand wants to relax. Hold that feeling in your mind, because in a moment, I am going to explain why an older body under the stress of major surgery is doing something very similar, working at its absolute limit, with far less room to recover if something goes wrong. Let me explain something that changes how every one of the next 5 surgeries should be understood. Think of your body's physical reserve like a phone battery. A healthy 40-year-old body walks into surgery with a battery sitting around 90%. A frail 80-year-old body might walk into that same operating room at 15%. Both phones can turn on. Both patients can survive the surgery itself. But only one of them has enough reserve left to survive hours of stress on the heart, the lungs, the kidneys, and the brain without the whole system shutting down somewhere along the way. Doctors have a specific word for this: frailty. Frailty is not the same thing as age. It is a measurable medical state where the body's reserve has dropped below a safe threshold. Research in geriatric medicine consistently shows that roughly 40% of people over 75 show measurable signs of frailty, and that number climbs close to 60% in people over 85. So the real question before any major surgery is never simply, can this person survive the operation? The real question is, can this person survive the recovery? Those are 2 very different questions, and that difference is about to matter a great deal. Surgery number 1, open heart surgery in a frail patient. Coronary artery bypass grafting, or bypass surgery, is one of the most common major operations performed on older adults. The concept itself is simple. An artery feeding your heart is blocked, and a surgeon reroutes blood flow around that blockage using a healthy vessel taken from elsewhere in the body. For the right patient, it works remarkably well. Here's the part rarely explained in full. Open heart surgery of this kind requires stopping your heart completely, while a machine outside your body takes over the job of pumping blood and delivering oxygen for you. Think of it like handing the keys to your entire house over to someone else for several hours while they take care of every single room. Even if they do a careful job, when you get your house back, a few things have been rearranged, some pipes were touched that did not need to be, and it takes real time before everything feels like your own home again. That is close to what a heart-lung machine does to your whole body, not just your heart. For a healthy 60-year-old, that handoff is usually smooth. For a 78-year-old with kidney disease, mild diabetes, and early memory changes, that same machine is asking every organ in the body to absorb stress at the same time. Research that follows frail elderly patients through open heart surgery shows a 30 to 40% risk of a major complication, stroke, kidney failure, prolonged confusion, or extended time on a breathing machine. And in the highest risk group of elderly patients, up to 15% do not survive the first 30 days after this specific surgery. So what is the alternative? In many cases today, there genuinely is one. It is called angioplasty and stenting, a catheter-based procedure that reaches the blocked artery through a small opening in the wrist or the leg, without ever stopping the heart or opening the chest. It is less dramatic than open heart surgery, and it is not the right choice for every blockage. But it exists, and it deserves to be part of the conversation before a decision gets made. There is also a middle path worth knowing about for many patients, a structured medication protocol combined with supervised cardiac rehabilitation, a program where your heart is strengthened gradually under professional supervision rather than pushed through a single high-stress event on an operating table. Does this mean you should refuse open heart surgery if it is recommended to you? Absolutely not. It means you ask one direct question: am I a candidate for a less invasive approach to this specific blockage? That single question can change everything that follows. Surgery number 2, aggressive spinal fusion. Back pain in your 60s and 70s is almost universal. I do not know a single patient over 70 who has never mentioned their back to me. And the solution offered more and more often is spinal fusion, hardware inserted to lock several vertebrae permanently in place so they can no longer move against each other. I need you to hear this part clearly. Some spinal surgery is absolutely necessary, no question at all. A spinal cord that is being actively compressed, causing loss of bladder control or the start of paralysis, needs surgical intervention right away. But many patients believe that if a surgeon recommends spinal fusion for chronic back pain, it must be the option with the best outcome since it sounds like the most decisive fix. That belief feels reasonable. It is also not accurate, and I want to walk you through exactly why. Once several vertebrae are fused rigidly together, the sections just above and below that fused area have to bend and flex far more than they were ever designed to, almost like a zipper with several teeth locked permanently shut, forcing the teeth just above and below that section to absorb all of the movement by themselves. Over years, those surrounding segments are often the ones that begin breaking down first, a pattern surgeons call adjacent segment disease. Research examining complex spinal fusion in patients over 65 has found complication rates exceeding 40%, and the most common complications are not minor blood clots, infections, and hardware that fails to hold. And here is the part that frustrates me most as a doctor. Studies in this population consistently show that for many patients with ordinary degenerative back pain, aggressive fusion surgery provides no better long-term pain relief than physical therapy combined with targeted injections. No better relief, but dramatically higher risk. A colleague of mine, a brilliant spine surgeon, once told me, sometimes the best operation is the one you do not perform. I think about that sentence often. Physical therapy combined with a targeted injection sounds far less dramatic than surgery. And for many patients with ordinary degenerative back pain, that is precisely the point. A lower risk path that in the research often performs just as well over time. Have you ever been told surgery was your only option for back pain? Write that in the comments. I want to know how many of you have heard those exact words. Surgery number 3, major cancer resections in a frail patient. This is the hardest one to talk about because when someone hears the word cancer, the instinct is immediate. Remove it, cut it out, get rid of it completely. I understand that instinct completely, I would feel exactly the same way. But nearly 15 years of working alongside surgeons has taught me something important. The goal of any cancer treatment is not simply to remove the tumor. The goal is to give the patient more good years of life afterward. Let me give you a real example. Surgery on the pancreas for pancreatic cancer, sometimes called the Whipple procedure, is one of the most complex operations in all of medicine, often taking 6 to 10 hours to complete. In a younger, healthier patient, that surgery can genuinely be life-saving. But picture two runners crossing the very same finish line side by side. One has enough left in reserve to celebrate, the other collapses the moment they cross it. From the outside, both technically finished the race, but only one of them had the reserve to survive finishing it. In an 80-year-old with heart disease and reduced kidney function, that same surgery can technically succeed, the tumor is gone, and the patient still passes away within weeks, not from the cancer, but from the surgery itself. Surgeons who study outcomes in older cancer patients describe a specific pattern called failure to rescue, meaning a complication happens that a weakened body simply cannot survive, even with excellent care afterward. In some of that research, this happens in close to 1 in 5 older patients who undergo major cancer resection surgery. So what is worth asking your oncologist directly? Ask this exact question. If we do not operate, what does watchful waiting, radiation, or targeted medication look like for someone my age and my current health? That single question opens a door many patients never even knew existed, and sometimes what is behind that door is genuinely the better path for that specific person. Targeted medication therapy and modern radiation techniques have both improved substantially over the last decade, and for a frail patient, either option may offer meaningful extra time with far less physical cost than a 6 to 10 hour operation. Surgery number 4, elective joint replacement in a severely ill patient. Hip and knee replacements are among the most successful operations ever developed in modern medicine, and I say that without any hesitation. For the right patient, a new hip genuinely transforms quality of life, taking someone from barely walking to playing with their grandchildren again. That result is remarkable, and it happens every single day. But here is where it becomes more complicated for older adults specifically. The word elective means the surgery is planned, not an emergency. You have time to think, time to prepare, and time to ask whether right now is truly the best moment for your particular body. In patients over 75 who are also managing 3 or more serious conditions, heart disease, diabetes, or chronic kidney disease, elective joint replacement carries a meaningfully higher risk of complications, and the biggest danger is a blood clot. Picture a slow-moving river with logs building up quietly at a narrow bend. Most of the time, those logs simply sit there. But if enough pressure builds, one breaks free and travels downstream until it becomes lodged somewhere far more dangerous. That is very close to how a blood clot behaves after this kind of surgery, forming in the leg and sometimes traveling to the lungs. I want to be precise here, because I do not want to frighten anyone away from a surgery that might genuinely change their life for the better. The real question is never, should I ever have a joint replacement? The real question is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, weight, and cardiovascular health before an elective surgery can lower complication rates dramatically. Some hospitals now require a formal preparation program called rehabilitation before scheduling this surgery for a higher-risk older patient, and that approach is exactly right. Has your own doctor ever discussed rehabilitation with you before a planned surgery? Most people have genuinely never heard that word before, and they absolutely should have. Lying still for too long after surgery raises the risk of pneumonia and hospital-acquired infection as well, which is exactly why modern recovery protocols now push patients to sit up and move within hours of surgery instead of days, even when that first short walk feels genuinely difficult. Surgery number 5, emergency abdominal surgery. Now I need to pause here for a moment because this one is different from the other 4. You do not choose emergency surgery, it chooses you. A perforated bowel, a ruptured appendix, sudden internal bleeding. These situations do not wait for a calm conversation in an office. But here is exactly why it belongs on this list. Knowing the real risk in advance, before an emergency ever happens, changes how a family makes decisions in those terrifying, fast-moving moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery, in the most severe cases somewhere between 30 and 50%. Not because surgeons lack skill, but because an aging body under sudden trauma is fighting on too many fronts at the exact same time. Picture a city power grid during a heat wave. When one substation becomes overloaded, it does not simply go dark on its own. The extra load shifts to the next substation, and if that one cannot absorb it either, the failure spreads block by block until much of the city goes dark at once. Something close to that can happen inside the body during a sudden, severe surgical emergency, a cascade doctors call systemic inflammatory response, where multiple organs begin shutting down one after another. So what can you actually do with this information right now? Two things. First, do not ignore abdominal symptoms. Persistent pain, bloating, or a real change in bowel habits in anyone over 60 deserves prompt medical attention, because catching a problem early is often what prevents it from ever becoming an emergency at all. Second, have the conversation with your family now, not in a hospital hallway at midnight. What would you want if emergency surgery were the only option? What quality of life matters most to you? These conversations are not morbid. They are one of the most loving things you can do for the people who might one day be standing in that hallway. A change in bowel habits that lasts more than a few days, unexplained bloating that does not resolve, or pain that keeps returning are not symptoms to wait out over a long weekend. They are exactly the kind of symptoms worth a same-week phone call to your doctor. I see this exact pattern constantly in my own practice. A patient comes in, often in their 70s, having already been told by more than one specialist that surgery is simply the next logical step, with very little real discussion of anything else. I think of a patient I will call Walter, 74 years old, a retired aerospace engineer here in Denver, sharp-minded, still building small model aircraft in his garage most weekends. 3 different specialists had recommended open heart surgery for a blocked coronary artery. 3 specialists, 3 separate recommendations, the exact same answer every time. Walter was not afraid of surgery itself. He was afraid of losing himself. He had watched his own wife go through a major operation 2 years earlier and come out of it confused, exhausted, and never quite the same person she had been before. He told me once, "She went in as my wife, and she came out as someone I had to take care of." That sentence has stayed with me ever since he said it. When I reviewed Walter's full picture, his kidney function, his frailty score, his overall cognitive baseline, I sat down with him for 40 minutes, not the usual 15, and I told him the honest truth. Surgery was genuinely an option for him. So was an aggressive medication protocol combined with supervised cardiac rehabilitation. For his specific profile, the data showed comparable 5-year outcomes between both approaches. Walter chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph of himself standing at the top of a hiking trail with his 2 granddaughters, both taller than him now, grinning like he had won something enormous. His cardiac rehabilitation was not easy. There were weeks where his numbers barely moved, and weeks where he genuinely wondered if he had made the wrong choice. But his medical team adjusted his protocol along the way, and slowly, his heart got stronger without ever going anywhere near an operating table. Here is what I need you to understand, and it may be the single most important thing I say in this entire video. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions made about your own body. You are an active participant in your own care. Every single time. I want to say something plainly, because it deserves to be said honestly. Part of the reason these conversations happen so quickly is structural, not personal. There is no billing code that rewards a surgeon for spending 40 unhurried minutes discussing an alternative to their own operation. A 15-minute pre-operative appointment is simply not built for that kind of conversation. This is not a criticism of any individual surgeon, because most surgeons went into medicine wanting exactly the opposite of a rushed decision. It is simply how the system around them is built to move quickly toward treatment, not to slow down and fully weigh every alternative. This is not unique to any single hospital or any single surgeon. It shows up across the entire system because the incentives that shape modern medicine reward action over conversation, and a signed consent form moves a patient toward treatment far faster than a long, unhurried discussion of alternatives ever will. Once you understand that, you stop waiting for someone else to slow the conversation down for you. You start doing it yourself, on purpose, every time. Here is what I want you to take from everything we have covered so far. None of the 5 surgeries I described today are surgeries to be afraid of. They are surgeries to be informed about. I have sat with families in a waiting room, watching them realize too late that nobody had ever explained the real risk clearly enough for them to ask a single follow-up question. That moment of realization is heartbreaking, and it is almost always preventable. If this video changed even slightly how you think about a surgical decision, in your own life or in someone else's, please take 15 seconds right now and share it with them directly. Send it to your spouse, your sibling, your adult child, anyone who has an appointment like this coming up. This is exactly the kind of information that should never stay locked inside one single video. And if you are not subscribed to this channel yet, this is the moment to do it. Every video like this one exists because people just like you decided this information mattered enough to keep showing up for it. Subscribing costs you nothing, and it means the next hard question you should be asking reaches you before your next appointment, not after it. Before I move into exactly what to do with everything we just covered, I want to ask you a quick question, and there is a real reason behind it. How old are you right now? Type your age in the comments below. I ask this on every single video, not out of curiosity, but because surgical risk, recovery expectations, and even how aggressively to pursue alternatives genuinely shift depending on your age and your current health. Knowing who is actually watching helps me shape exactly what I cover next, so the advice reaches the people who need that particular version of it. Let me ask you something that might sting a little. If every consent form you have ever signed had to include one honest sentence, written by the surgeon, describing exactly how many patients like you did not walk out the same person who walked in, would you still sign as quickly as you did? Most people assume they already know that answer well enough. In my experience, most people do not, because nobody ever puts that sentence in front of them. Trust is not the same thing as information. You can trust your doctor completely and still deserve every piece of information that trust is currently standing in for. Remember that pattern I described at the very start of this video: trust the recommendation, sign the form, survive the operation, come out permanently changed rather than simply better. The entire purpose of everything we have covered today is to break that cycle at exactly one point, the moment right before the signature, by replacing blind trust with informed trust. That is not distrust of your surgeon. That is partnership with your surgeon. And every good surgeon I have ever worked alongside genuinely welcomes that kind of patient, because an informed patient makes better decisions before, during, and after the operation. I would love to hear from you directly in the comments. Have you or someone in your family ever faced a major surgical decision like the ones we discussed today? Sharing your story does more than you might realize, because someone else reading it may recognize their own situation in yours, and that recognition is sometimes exactly what pushes a person to ask one more question before signing anything. And while you are there, tell me what question you would most want to ask your own surgeon before a major operation. I read every single comment, and it genuinely shapes what I record next. So let me bring everything together into something you can actually use the next time surgery is recommended to you or to someone you love. There are 4 specific questions every patient over 60 should ask before any major operation. Write these down. The first question: what happens if I do not have this surgery? A good surgeon will give you an honest answer. If nothing urgent changes over the next 6 to 12 months, you have time to think, time to get a second opinion, time to strengthen your body first. The second question: is there a less invasive alternative available for my specific situation? Medicine has changed enormously over the last 15 years. Robotic surgery, catheter-based procedures, and endoscopic techniques that simply did not exist a decade ago are now available at most major hospitals. The third question: what does recovery realistically look like for someone my age with my specific health history? Not the average patient. You specifically. Your heart, your kidneys, your current medications, and your living situation at home. The fourth question, and this is the one almost nobody ever asks: what is your personal complication rate for this exact procedure in patients over 70? Surgeons track this information. They know their own numbers. A confident, honest surgeon will simply tell you, and if a surgeon seems uncomfortable with the question, that discomfort itself is information worth having. The fifth step: get a genuine second opinion and a third if something still feels unclear before any non-emergency surgery. This is not an insult to your first doctor. It is simply good, careful medicine. The sixth step: have the honest conversation with your family now about what quality of life matters most to you, long before any emergency forces that conversation to happen in a rushed and frightening moment. The seventh step: remember that asking these questions is not a betrayal of your surgeon. It is exactly the kind of partnership every good surgeon actually wants from a patient who is about to trust them with their body. None of this means avoid every surgery. Surgery saves lives every single day, and I have watched it change lives for the better more times than I can count. The message today is simply this: be an informed patient. Ask the harder questions. Request the alternative. Get the second opinion. Your age is not a weakness, and it is certainly not a reason to stop asking questions about your own body. Thank you for spending this time with me today. I know there is a lot of noise out there telling you what to fear and what to do, and I try very hard to make this channel something different, a place where you get the honest truth instead. If today's video gave you even one question to bring to your next appointment, that is exactly why I make these. If you are not subscribed yet, please consider joining this community because it genuinely helps more people like you and like Walter make a decision they will not regret later. One last thing before you go, and I say this because I genuinely care about you, not because I am required to. Everything in this video is general medical information based on established clinical knowledge and years of experience working alongside surgeons, not a diagnosis or a recommendation for your specific situation. Every person's health history is unique. Before making any decision about a planned surgery, please have a full, honest conversation with your own doctor or specialist. They know your history, they know your body, and that conversation, informed, direct, and unhurried, is exactly where good medicine and a decision you will not regret begins.